Thank you for showing up so early, and thank you for the invitation. And I trust that you've been enjoying Montreal and its very special orange cones all over the place, and that they haven't really caused you too much trouble, because they do cause us a lot of trouble most of the time. So my task is really to discuss more from the clinician perspective who receives your report, and see how we, we then kind of proceed with various steps in the management of patients who are at risk of fractures. And so I just want to highlight here the importance, of course, of your report, because for a physician, it's really important in that you're helping assess the risk for future fractures, or assess a risk, and the importance of the interpretation of the BMD and the spine imaging, if it comes with it, will really go a long way in guiding the clinician make their recommendation to the patient, so that they can come together to a management plan. So we're just going to go through the guideline more from a clinical perspective. So that's the idea. So osteoporosis really is a disease of bone strength. And as you know, the only outcome that we worry about is the outcome of fracture. And this is what is important to the clinician, particularly the family physician, is how do we prevent either a first fracture, but most importantly is how do we prevent second fracture. So secondary prevention is really the focus that we have in clinical practice, because often patients don't come to attention until they've had that fracture. So it's really an important point to take a prior fracture into consideration when we do, make the fracture risk assessment. And so, of course, the bone mineral density becomes important, because this will refine the fracture risk assessment, if that's what we're doing it for, or will allow the clinician to see whether the treatment that the patient has been taken is actually effective or not. So these are the main two reasons why bone densities are done. So as we all know, osteoporosis is a disease of the older women. However, men are most of the time underdiagnosed and undertreated, even if they're known to have had fracture. And this is despite the fact that men suffer worse outcomes than women following fractures. They refracture more rapidly, and they have a lot more morbidity and excess mortality following a fracture than women do. And so 1 in 3 fractures actually occur in men, particularly after the age of 70. And of course, fractures are associated with increased mortality, morbidity, as I've mentioned, and very important to patient loss of autonomy. And of course, once you've had the fracture, your risk for having another one is extremely high, particularly if this fracture is one of the spine, the hip, or if it's a recent fracture. So you can see on the right-hand side really how fractures, the age annual rate of fractures, both in men and in women. And you can see that the pattern of skeletal fractures at the various sites actually mirror each other, but in men it's obviously less prevalent. But after the age of 70, the pattern is the same. Hip fractures, spine fractures, pelvic fractures, humerus fractures. These are major osteoporotic fractures and should be reported and taken into consideration as providing a very high risk for future fractures. So this is really important, both in men and women. Now, this is here, the scale is obviously not allowing you to see the extent of the care gap, but you could see here that this is the people who receive a medication in the year following the fracture. So this is Canadian data. It comes from PHAC. And what it shows here is in the year following a fracture of the hip, the spine, the wrist, or the pelvic or the shoulder, 25% of women or so receive treatment, and approximately 10 to 15% of men actually will receive treatment. So this is just treatment. BMD is actually worse, and I haven't shown it, but men receive a BMD in 5% of the cases. So there's a lot of work to be done in ensuring that the guideline recommendations are uptaken just only if for secondary prevention. It's not to say that everybody should be on treatment, obviously, but it certainly should be higher than 25% of the time. So the Canadian guideline update took us quite a while, and I thank Steve for having been on the panels as well. It took us about 2.5 years to be able to come up with the final guidance, and that's what they are, they're guidance. And so as you know, for any guideline, there's always a lot of discussion, review of the evidence, and in the end, part of it can be compromised, particularly in the area where the evidence is not as strong. So our target audience for the guideline is really the primary healthcare professionals, because this osteoporosis is really a disease that is managed or should be managed by primary healthcare professionals. And we're targeting essentially postmenopausal women and men 50 years and older. And again, this is important because we're not looking at people who are 40 years old, and we're not looking at secondary osteoporosis such as the one that is associated with cancer treatment or steroids. So there are guidelines for this, and of course we will be looking for these risk factors as we assess, but we're not specifically providing guidance for these patients. So we used the GRADE approach, as I will show you, and we had various panels or working groups to which we had, on each of these panels, we had at least one or patient partner and a family physician. So to ensure that we had, the people with the lived experience and those who are going to use this guidance as well, and then a set of researchers, clinician experts in various topics, and we also had a GRADE methodologist expert, who kept us in line because it is a complicated process. And so the GRADE approach takes into consideration the evidence, obviously, but it also takes into consideration feasibility, patient with the lived experience, the importance that the recommendation is to them, as well as cost to the jurisdiction or the country. And so there's various steps to consider, and it's not just about the evidence. And so in the GRADE process, you then have either strong recommendation or conditional recommendation. And we understand that this kind of vocabulary may seem complicated for nothing, but there's a big difference in between we recommend and we suggest. And so recommend is a stronger recommendation. It uses that word to say that most people would do that, most clinician would do this, and most patient would agree with this. And suggest means that the evidence and or other issues are less strong, and that the majority may do it, but there's a significant proportion of people who may not do it based on their values and preferences and so on. So throughout the guideline, you'll see we will use, and I will highlight when it is a recommendation and when it is kind of a suggestion. So we have 25 recommendations, 10 good practice statements. Good practice statements are recommendation for which we did not review the literature because essentially it kind of seems obvious, such as people should wear a parachute if they jump off a plane, and so we don't do a review of the literature for these types of statements. So there are some changes from the previous 2010 guidelines. As I've mentioned, the GRADE framework, we have different screening criteria for BMD, and then we have other, recommendation, as you could see on the slide. So the initial step really is to do a fracture risk assessment. So we have our population, 50 years and older, postmenopausal females and males, and then when at the age of 50, it is recommended that you do a fracture risk assessment. And so this fracture risk assessment really is to seek out the risk factors that could put your patient at higher risk for fracture. So you're seeking out these risk factors, and essentially you will note that they're the same that are incorporated in the FRAX tool. So we're looking at these factors because we know that they've been associated with fracture risk independently of bone density. So we're looking for these factors, and you will note that the glucocorticoid, for those who do this frequently, the dose has changed a little bit to align with the risk factors. And so we then recommend a bone mineral density test in those, depending on the age, in those who have the presence of clinical risk factors. And the idea is that by adding a bone density, you may refine their risk, or you may be able to better assess their future risk. So you will note that now we recommend that people who are age 50 to 64 have a bone density, but we're very prescriptive in that they have to have had either a fracture or two risk factors, whereas previously we said anybody over the age of 50 with clinical risk factors should have a bone density. So we're a bit more prescriptive here. Those with who are age 65 still have to have at least one clinical risk factors among the ones that we're showing, which includes fall as well, I should say, and fall is not incorporated in FRAX. And then kind of universal screening for people over the age of 70. So this was previously at the age of 65, this universal screening, but now it's above the age of 70. And there's still some, and so this is a conditional recommendation. So we suggest, all right, because the evidence for this is stronger in females than it is for males. So there are randomized controlled trials in females, but there are none in males. And so the Canadian Task Force on Preventive Healthcare, whom you may be aware of, has come up with guidelines that are different than the ones that Osteoporosis Canada came up with. And so the Canadian Task Force heavily relies on RCT data to make their recommendations. And we obviously relied on RCT data, but we also relied on evidence that comes from observational studies. And so the Canadian Task Force recommends screening, so universal screening only in women over the age of 65, and that no screening be done of men or of younger women. And this is based on the fact that there are no kind of strong evidence, and based on the fact that the family physicians are extremely busy and should not spend time doing screening processes in people where there's no evidence. So, however, they do say that if people have had fractures, then obviously secondary prevention strategies should be incorporated. So this is what, the Canadian Task Force says. I've told you what we suggest. And we know that for the males, it is a lower grade level because the data are not as strong. So vertebral fracture assessment is also something that we do suggest that people do, particularly if on physical exam they have signs of possible vertebral fractures. And if they don't have signs, then we do suggest, that people who are over the age of 65 and have an osteoporotic T-score have a vertebral fracture assessment, or if their risk for future fracture, as you'll see later, is in between 15 to 20%. The reason we suggest is that when there is evidence of vertebral fracture on the assessment, this will change the category of risk, and this may also change the initial treatment that the clinician will choose to use. Now, you can do a regular spine, radiograph, or you can do a VFA as is used from the DEXA imaging, and that depends very much where you work. In Quebec, we don't have access to VFA. We have access, we get the reports for the lateral spine radiographs. And so here is how we kind of put it all together in terms of fracture risk assessment. So we suggest that people use the FRAX tool. And, I think Steve and Dr. Leslie will go more into details about this. But essentially, the FRAX tool tends to predict more accurately the risk for future fracture because there are more data points entered, and also because there's a new FRAX tool that will be coming out within the next 2 years or so with incorporation of new important risk factors such as falls, possibly diabetes, and other medical conditions. So essentially, you do need to enter these data points. And if you are unaware of the answer, then you should leave it conservatively to know. What's important to know is, of course, that all these tools that we have tend to underestimate fracture risk in those people who have had multiple fractures, who have had a recent fracture, and who have had a fracture of the hip or the spine. So the hip and the spine really predict short-term, very high risk. And so because it's yes or no in the FRAX currently, it tends to underestimate this. Now, this will likely be incorporated in the new FRAX tool, recency and also site of fracture. There is a FRAX Plus, which is currently available on the FRAX website. You can go to it. And however, it is actually, you have to pay for this, but you can add these various other risk factors as well. So once you've obtained your BMD and calculated your 10-year fracture risk, you can then kind of proceed to assess where your patient falls in terms of categories of risk and whether they have to, whether they should undergo treatment or whether we should suggest pharmacotherapy. So the right-hand side is really important. People who've had a previous hip, spine, or more than 2 fragility fracture events do not need a bone density for treatment initiation. They should just be treated. If you want to do a bone density, it's going to be really to assess the effect of your treatment on the bone density. And so those who have not had these fracture events, then you go down, and if they have a 10-year fracture risk above 20%, or if their T-score, and this is new, T-score below -2.5 with an age over 70, are considered to be at high risk because there are data that support that older people who have a low T-score respond better to treatment than those whose T-score is lower. It's not that they don't respond, the ones with the lower T-score, but they have a better response. So we recommend pharmacotherapy in that group, and then, you could see for yourself the NNTs and how things move towards the left side. So quickly, we recommend, obviously, exercise and calcium and vitamin D and in everybody. So this is just not for people who are considering risk of fractures, but this is really important. And so we encourage that. In terms of vitamin D, briefly, the recommendations are now changed to stating that we should meet the requirement or the daily dietary allowances through the diet or by providing a supplement. And we don't need very large amount of supplements in order to achieve the level of 50 nanomole per liter, which is actually required for a healthy bone. So vitamin D and calcium do not prevent fractures in people who are vitamin D replete. They are just there to maintain bone health and to avoid a low level of 30 that would put the patient at risk of either osteomalacia or rickets if they're young. So we aim for a level of 50 and above, and that 600 or 800, depending on the age group, will provide you enough vitamin D to do that. In terms of calcium, we don't recommend supplements. We try to get it from the diet because there are other nutrients that are available, such as protein, magnesium, phosphorus, that come with the calcium when you eat it through your diet. If you can't, yes, we then recommend a supplement, but not more than 500 milligrams per day. In terms of exercise, we don't recommend aerobic exercise or pounding the pavement. We do recommend resistance exercise because we know if your muscles are strong and toned up, this will kind of stimulate bone cells, the bone-forming cells, osteoblasts, and this will lead to better bone strength. And there's obviously data to support that. So balance and functional exercise to prevent falls and resistance exercise to promote osteoblastic activity and improvement in bone density. In terms of treatment, there's really two families of medication. There are those that reduce bone loss and those that promote bone formation. So we have the anti-resorptive medications, which have been on the market for a long time, bisphosphonates, denosumab, and the hormone replacement therapy, although they're not as potent as the two other categories. And then in terms of anabolic agent, we have two families of medications. The PTH receptor agonist in Canada, we only have teriparatide, and in the anti-sclerostin antibody, which is romosozumab. So the anabolic agents are more expensive. They are usually reserved because of provincial jurisdiction and provincial reimbursement program to people who have more severe disease or whom the risk for fracture is higher. So we usually use as a first-line therapy bisphosphonates. So you will see here kind of the effect of these agents on bone density, and through bone density effect, we have an effect on fracture reduction. And so the kind of the panel on the right-hand side, where you can see essentially that all of these molecules have a good effect or strong impact on vertebral fractures and a lesser effect on non-vertebral fractures, but nevertheless, they do reduce the risk of non-vertebral fractures. And this is a compilation of multiple RCTs together. And then on the left-hand side, you can see how the bone density improves following certain treatment. And I'm not going to spend time on this, but this was just to show you that we do have data for this. So you do initiate treatment. The recommend side, which is the side where your patient's at the highest risk, and these are the people who will benefit the most. So these are people who've had a fracture, so we recommend therapy. And those whose the risk is less, which is from 15 to 20% or a low T-score, then we suggest therapy. This entails a kind of longer conversation with our patients. How do we approach therapy? So following the report, following the bone assessment and bone density assessment and the risk, then we see how we approach this. And usually the first line, as I've mentioned, are bisphosphonates. And bisphosphonates are very efficacious medication, and they're usually well tolerated. There are contraindications to bisphosphonates, however, kidney failure, intolerance, or GI intolerance, and so on. And so in those cases, denosumab should be the first, line of agents. Now you will see that at the top, there's right immediately a kind of a place where you can actually go directly to anabolic therapy, and that's if you've had vertebral fractures, a severe vertebral fracture, or more than 2 with a low T-score. That kind of brings you over to anabolic therapy because there are data that support this approach. And multiple guidelines also suggest that those at very high risk, this is what they call them, or imminent risk of fracture, be considered for anabolic agents. Now, monitoring, so as you know, people monitor obviously through clinical evaluation, but BMD is the test that we do to see whether there's either a loss or maintenance of bone density. And so our good practice statement says that we should do regular clinical assessment, but we suggest a bone mineral density measurement 3 years after initiating pharmacotherapy. Now, most people, as you know, will tend to do them every 18 months, every 2 years. People are uncomfortable not having a test to tell the patient, listen, you're doing better. But there are not a lot of randomized controlled data to show that monitoring will lead to fracture reduction. And so that's the problem. So we do have observational data from the Manitoba BMD registry that shows that if you are able, in the panel at the bottom here, if the patients improve their bone density, then their risk for future fracture decreases. And the mean interval of bone density was every 4 years in that study. Now, in the study up, you could see that with the change in bone density, we have a reduction in fracture risk, which is why we actually suggest that people follow bone density. And we don't recommend bone turnover markers. That's a serum test, and in fact is not yet for screening. So when do we recommend that those who are not on pharmacotherapy have another risk assessment, including BMD, if they meet those criteria that we've mentioned before? So if the risk is very low, then it could be up to 10 years, 5 years if the risk is in between 10 and 15, and 3 if the risk is higher. You'll notice that we only use the major osteoporotic fracture risk and not the hip fracture risk assessment as they do in the US, for example. So how long do we treat people? So we treat people with bisphosphonate for 3 to 6 years. So this is new guidance. Before we said people should consider a drug holiday. Here we prescribe more the duration. And the reason for this, as you know, is because of the risk of atypical femur fractures particularly, and because also there are not that much data that supports going on for a prolonged period of time in terms of fracture reduction in people who are at risk of fracture. So 5 years and the 5 extra years, that's the FLEX trial. And then there's one with zoledronic acid and intravenous bisphosphonate that showed that you could probably reduce vertebral fractures, particularly radiographic vertebral fractures, but you don't have a big impact on non-vertebral fractures if you continue the bisphosphonate for prolonged periods of time. And on the right-hand side, you could see that the incidence of atypical fractures, even though it is a rare event, does increase with cumulative use of bisphosphonate. And actually, that risk goes down fairly quickly after stopping the medication. So that's why we recommend 3 to 6 years of treatment. Now, in those who take denosumab, which is a potent anti-resorptive, the problem is that once you stop the denosumab, your bone density gains, as you can see on the left-hand side, will go down very rapidly. So you lose your bone density gains in about a year after stopping the medication. And this rapid bone loss that we see on BMD translates into an increased risk of vertebral fractures and multiple vertebral fractures in people who have been on the denosumab for a long time and those who actually had vertebral fractures at baseline. So we do not recommend a denosumab holiday. We recommend that these people stay on the medication for prolonged periods of time, and we follow them accordingly to encourage adherence to therapy. Now, the anabolic agents are usually prescribed for only a set period of time, and that's usually because the studies were done in that manner. So it's not that we're giving a holiday, it's the end of the treatment, and we then follow the anabolic agent with an anti-resorptive agent, so to prevent that loss of bone that will happen if you actually don't give an anti-resorptive agent. Now, there are studies looking at combination of treatment and anabolic with an anti-resorptive or one, overlapping the other. Still, it can be used in very selected patients, but this would be really in specialty. So in conclusion, osteoporotic fractures have important consequences in both men and women, obviously. And what is really important is those who've already sustained a fracture should be identified, and there should be a clear recommendation to treatment. All right, so this is really important. Screening for clinical risk factors, this is what we do in our clinical office, but then we need your reports to support our clinical assessment and then our ability to guide patients in treatment decision. And I think I'll stop here. Thank you.
Thank you so much, Suzanne. That was a comprehensive